This is SelfWork, and I'm Dr. Margaret Rutherford. At SelfWork, we discuss psychological and emotional issues and what you can do about them, whether that's learning self-acceptance, taking action, or seeking therapy or treatment. 10 years ago, I extended the walls of my practice to reach those of you who might already be knowledgeable about mental health treatment, but also to those of you who might say you'd never darken the door of a therapist. And yet, you are here. I'll answer your questions while I invite you to take a few minutes for your own self-work.
For persons of color, there's an added layer to identity development and becoming secure as who you are and in who you are. And so part of the approach that I take is like helping people see the beauty of all shades and helping people get to a space of acceptance of who they are, and that society doesn't set the standard for beauty, you set the standard.
Welcome to this week's edition of SelfWork. We talk more openly than ever about the benefits of therapy, but less about the ways therapy can unintentionally cause harm. And harm does happen far too often with therapists who do things or say things that hurt their clients. Maybe it's oversharing, being dismissive of something their client is trying to describe, or even letting a client know of an attraction to them that they feel. That just infuriates me. All of those things are highly unethical. Every profession has people in it that don't meet even a minimum standard of care. But the vulnerability that therapy clients walk into therapy with needs to be respected. They are asking for help. Today, psychologist and mental health advocate Dr. Patricia Dixon is shedding light on the often misunderstood concept of therapy harm. She explains what it is, how it can happen even with the best intentions and sometimes without them, and why clients who experience it often struggle to speak up. We're also going to focus on what's called colorism and how she addresses that in her teaching and practice. Who is she? Dr. Patricia Dixon is a licensed clinical psychologist, speaker, author, life coach, and professor based in Tampa Bay, Florida. She's got a doctorate in clinical psychology and specializes in diversity and multicultural issues, relationship counseling, self-improvement, and mental wellness. A breast cancer survivor, she draws on her personal experiences to empower others, particularly in the areas of couples therapy and self-relationship development. But before we go on, let's hear from BetterHelp. The most common problem I hear from those seeking therapy is how hard it is to find a therapist, how long it takes, how vulnerable you feel asking around for names. BetterHelp solves those problems. After you make the first contact, their standard is to offer names of therapists to you in less than 2 days. And you can talk to them in a first session to see if it's a good fit. If so, you're on your way. But if not, rather than going through something awkward, you simply let BetterHelp know, and they'll ask what it was you didn't like and find someone else for you. You can text, chat, or talk virtually. All of those avenues are open to you. I'm a therapist because I got good therapy. I had no idea how much I could benefit from it, but I knew I wasn't seeing myself or my world clearly. Here's BetterHelp's offer for SelfWork listeners: 10% off your first month of sessions if you use this link, BetterHelp.com/selfwork. You know, they say the best time to plant a tree is 30 years ago, but the next best is today. It's never too late to reach out and get help. BetterHelp.com/selfwork. And now, Dr. Patricia Dixon. As soon as I read the topics that you are interested in talking about, I knew that I wanted to have you on the program because I'll let you, you talk a lot about therapy harm, and you have several writings about it and that kind of thing. And so I think a profession that can't look at it self-critically that's not good for the profession. So first, tell us a little bit about you and who you are and where you are and how you got to be a psychologist.
Certainly. And I do want to say I appreciate you having me on. I'm pleased to be talking to you today, especially about topics that I'm very passionate about.
Yeah.
So my name is Dr. Patricia Dixon. I'm a licensed clinical psychologist. I operate in the Tampa Bay, Florida area.
Okay.
I have a group practice where we see a variety of clients from children all the way to the aging population. So we see a little bit of everyone with every presenting issue. And because of that, I'm very passionate about talking about topics like therapy harm. Because one of the first things I ask everybody who I see is if it's their first time ever experiencing therapy
Yeah.
and what their previous experiences was like.
Mm-hmm.
In addition to having my clinical practice, I also am a professor of graduate studies for a graduate school that's also located in the Tampa Bay area. I love being a mentor to those
Oh,
students
great.
coming in so that they can prevent being, one of the therapists that do harm. Like that's the goal is for us to be helpful, not harmful.
And you're a pet lover.
Yes, you'll see in the background. That's my little guy, Buddy. He does come to the office with me, and so his job is to greet everybody with a toy. So,
I think that is so cool. Hello, buddy.
yeah, he's somewhere walking around.
Yeah, I see him back there.
Yeah.
So, and you're also a Black psychologist and and you're a
Yes.
life coach. And so you also talk about issues with people of color. And I want to talk about that too, because I'm fascinated with what you have to say about it. So where do you want to start?
I will start and you lead, I'll follow. I will say like one of the things regarding the diversity, that's a extreme passion of mine.
So why don't you start first with what you've learned and what you're concerned about therapy harm?
Okay, so regarding therapy harm, I in fact have had like a few clients coming in, and part of why they were coming into therapy was they were seeing a previous therapist who did some things that are very unethical in terms of what their approach is and their conversations with the client who had already experienced trauma. And so,
Yes.
we always have to remember as clinicians, we have a great responsibility for the individuals who are coming to see us
Mm-hmm.
because they are already coming with baggage where they're seeking help. And so with this particular client, they were cautious. It took them a year before they sought therapy again.
Yeah, I bet.
And what they expressed to me of some of the things that this previous clinician had said to them and expressed to them was alarming. The therapists themselves overshared. I'm somebody where I don't think that self-disclosure is a bad thing when used responsibly.
Mm-hmm.
But that particular clinician self-disclosed things that made the client then feel responsible for taking care of them.
Sure.
And as a result, also triggered some of their childhood trauma of the most vulnerable things that they had ever shared with anyone.
Mm-hmm.
This clinician then made it about them
Oh,
and then also said just inappropriate things that like maybe alluded to some attraction towards the client, which triggered their trauma. And so hearing this person's story and their hesitancy of now coming to see me as their clinician and the questions that they had regarding what's your process if you want to stop seeing a client, because the other part was the therapist sort of just did client dumping once the client expressed some of their concerns. And so like again, I have this passion where the first experience for a client should be one where they're seeking help and they receive help. And I think as clinicians, we have to take that self responsibility of knowing what areas we are competent in
mm-hmm.
and then what areas somebody else would be a better clinician
Mm-hmm.
for,
Mm-hmm.
and being able to refer out when it's outside of our competency level.
Mm-hmm. Although the example you gave is really not necessarily about competence or saying in that area, it's more about this therapist's demeanor and their choices of what to
Mhm.
share and to talk about attraction towards someone and this
Mhm.
kind of thing. And so that is not a healthy therapist. I mean, that person is not healthy and doesn't know what they're doing, obviously.
Right.
Did you
And
report?
oh, most definitely. And
Good.
the client did as well. Um,
Good.
and that's where a lot of her therapy was in trying to get the courage to be able to report and say and share her story to gain her power back.
Well, let me ask you a question because I did this episode on cultural humility. And the reason why I did it was because I got a very respectful voicemail. I invite listeners to send me voicemails or emails,
Mm-hmm.
whatever. And it was from a young woman of color, a black woman.
Mm-hmm.
And she said, I think you give helpful advice. I think that, you seem compassionate, but you're white.
Mm-hmm.
And that means you've had privilege that many of us have not had. And what she was saying, it somewhere, either I had written it or said it, I was said, potential we all have is what I was talking about, some kind of potential, reaching your potential.
Mm-hmm.
And she said, I don't know if you understand as a white psychologist, as a white woman, older woman, what that really means to people of color. And
Mm-hmm.
I was so struck by her comment, and really wanted to treat it very seriously, that I did say that at least I try to have cultural humility built into my practice, but that's really not. So what do you think about that? Do you think that, we need many more therapists of color and we need so much more diversity in the therapy world. And so
By far.
what are your thoughts about that?
So that's again an area of passion for me because there is this need of realization of the different paths that we all walk down in life and
Mm-hmm.
what we encounter on those paths.
Mm-hmm.
And there once upon a time, the way the our field worked was we did a lot of client matching, client therapist matching. So if you're a Black psychologist, you find a Black therapist, or sorry, if you're a Black client, you're looking for a Black therapist. If
Yeah,
you are a
which is
woman, you're looking for
understandable.
a female. Yep, it's just the matching piece. But what research has shown is that that's less important than cultural competence.
Mm-hmm.
When a clinician has a level of cultural competence, even when there's differences in background, they still can be just as effective. But it does require the cultural humility of understanding my worldview and world experience is different than that of
Yes.
somebody who's been part of a marginalized population or a population that's faced different discrimination in society, and that affects the way that they navigate and experience you as a clinician,
Mm-hmm.
and also how they might feel you perceive them as a client.
Right.
And
That's an
so I
interesting
think that
point.
I think the cultural humility part comes in a willingness to acknowledge, like, I don't know. And, but I'm willing to listen and I'm willing to learn and I'm willing to be an ally.
So what do you mean about the way the client is perceived by the therapist, that the feeling they get in the session is maybe, uh, I don't know, just confusion or actually, I think less of you because of that, or
Yeah,
what?
it becomes this piece of like a question of, is this person going to understand that when I say I felt discriminated against, are they going to microaggress against me and make me feel like my experience is invalid or it's something different than I know it was? Or are
Mm-hmm.
they going to meet me where I'm at, listen to what
Mm-hmm.
I'm sharing, and see the validity in it,
Mm-hmm.
and have compassion for it and empathy for it?
Mm-hmm.
Um, because I think a lot of times when you're not put in a position to have to know about discrimination or have experienced it, you don't want to necessarily view the world from that lens. And so when somebody expressing their pain from the discrimination that they may have faced or experienced, there's a desire to excuse it away or make it something it's not,
Yeah.
or minimize it, instead of being like, that is awful. And
Yeah.
to have experienced that, um, is not just like a injustice, but is dehumanizing and deflating.
Mm-hmm. Mm-hmm.
And when somebody has that understanding, it allows a person of color or somebody from a marginalized population to be able to breathe and say, I can talk about real things with you because you get it.
So what other forms of therapy harm are you most concerned about?
So I'm also like, other than the area of like competency, there's also this piece of a lack of willingness to seek supervision when needed. I think especially because the only way we as clinicians become clinicians is through experience. But we have to realize when we are new, we're just being exposed to things for the first time, and we have to seek proper supervision for that. And then as supervisors, because I do supervise people at my, clinical site as well, or clinical practice as well. And so I'm very much intentional about talking to my students about the clients that they're seeing, because there is like the element of operating outside of what you are experienced in, making sure that you're not going just based off of a hunch, but what does the empirical literature say, and also what are the specific needs of the client. Another area that, like, other than the like diversity piece or lack of cultural competence in terms of therapy harm that concerns me is when clinicians aren't able to recognize when a referral is needed, when it's this matter of there's something that's happening between the client and the clinician that is inappropriate, and they're crossing boundaries into friendship versus it being like that respect of this client is coming to you because they're having genuine concerns that are occurring within their life.
So let's take a break, and we'll be back in just a moment. This episode is sponsored by BetterHelp. We talk about mental health more openly now, but asking for help can still feel hard. BetterHelp's 2026 State of Stigma report surveyed 2,000 Americans and revealed that 85% of Americans believe getting support is wise, yet 74% say society discourages people from doing so. So why, if most of us believe in support, why do so many discourage it anyway? A tough construction worker once told me, I had a bad shoulder, and everybody was glad I got into physical therapy. But if I have depression or anxiety or some kind of mental issue, why wouldn't they be just as glad that I sought help from a mental health therapist? It's common sense, but I think it comes down to one fact. Many problems aren't simply physical, they're mental and emotional. Therapists are trained to help you with that. BetterHelp therapists work according to a strict code of conduct and are fully licensed in the U.S. Don't let stigma stand in the way of support. Start therapy with BetterHelp. Sign up and get 10% off at BetterHelp.com. That's BetterHelp, HELP.com. So you talked about how the client had come in specifically to try to garner the courage to report and that kind of thing, which is a huge decision to do. What are you finding that prevents clients from talking about disappointments? I mean, it's funny, but it's not funny at all. I literally know someone, she's actually no longer living. So, but she would go to sleep on clients. And the client couldn't believe it, but there are lots of ways of going to sleep. I mean, you don't have to physically go to sleep. You can just stop listening. You can, all that kind of thing. And so what are you finding that clients talk about and need support for, or need to understand that this is something that they should not put up with?
I think the aftermath of therapy harm is a huge area in which we as clinicians have to be aware. If a client's coming to you and they've had like a bad experience in which harm was done, in order to rebuild that trust with a new therapist, they're having extra mountains to climb, extra obstacles to overcome, because they trusted someone before, and that person who they were supposed to be able to go to for help harmed them instead of help them. Yeah. And so I think we as clinicians have to err on the side of caution, of recognizing that building of rapport and that building of trust, there's added steps that we've got to take in reconciling the harm that was done, and then rebuilding their faith and belief that therapy could be helpful to them.
But what about the client themselves? I mean, they've been hurt in some way. they have felt either demeaned or ignored or avoided or manipulated or something, abused. And so what do you think? I mean, I'm thinking this also happens in the church. It happens
Yes.
in medical settings. It happens, in a lot of different settings. So what do you think is what is the motivation that seems to lead someone to say, I'm not going to carry this around the rest. I need to share this. I need to do something about this.
Is they still need and want help. It's this piece of like what their initial mission was hasn't changed. The initial mission was, I'm carrying something that I've been carrying for however long and it's too heavy for me. And now somebody added weight to it versus alleviating that weight. And so there's still the desire for help. But there's a caution and there's a fear that's now embedded, that we, like, again, as clinicians have to be aware of and be cautious with and handle with care. But the motivation for the client is that they know that they were seeking help and that the help that they were supposed to receive fell short. And with it falling short, there's hurt that's caused by that. In terms of, I was vulnerable with a person and this person said they would be able to help me. And instead they brought harm. They brought, more worries my way, more trauma my way. And you mentioned like that piece of like religious, harm, because that's another one that I, have worked with a lot of people on. But often, unfortunately, some of the people that are in, or some of the highest percentages where there's been therapy harm committed has been through Christian counseling. And don't get me wrong, because I'm not saying that there's anything wrong with Christian counseling. Um, um, it's more so this piece of operating within the realm of where competency is and not utilizing somebody's faith base as a tool of oppression, but instead utilizing it as a way of strength based, because there is a lot of research that shows faith based counseling can be helpful to those who adhere to a spiritual or religious belief system. But when a Christian counselor is operating outside of what they've been trained to operate in, it can be extremely harmful and extremely dangerous.
Yeah.
And so for the client, they're looking at it like, I was seeking help, I was seeking support, and I didn't receive that support. And there's something within them that has like this cognitive dissonance of sorts where they're like, this person says one thing and they're supposed to be in a position of authority for helping me, but something intuitively feels wrong about this.
Yeah. Yeah.
And so they're looking for a second opinion on, am I in the wrong or was it really this person? And I'll say one of the things that prevents people from ever reporting, is there's a fear of the stigma that might come back on them, where depending on what they've been diagnosed, they fear that this clinician or psychologist or Christian counselor will use their diagnosis in such a way that makes them say, oh, this is symptomatic of what they experience. It wasn't me as the authority within this field.
Right.
It's part of their symptoms.
Right. A form of therapy harm that may be somewhat subtle, but it's one of the reasons, well, I won't say that because maybe somebody will listen, but, is a sense of superiority, a sense of, us and them, those people with mental illness, my clients, rather than saying, well, that's me, I'm right in there.
Yes. Yep. Like we all have our different moments of difficulty and challenges, and that's what makes us human. And quite frankly, I think that's what helps us to be good clinicians is the human to human empathy of awareness of pain, but also the responsibility of what role am I in this particular person's life at this moment in time.
Right. Something I have been wanting to ask somebody for a long time, and I'm going to take advantage of this opportunity because you're a psychologist, but you're also a life coach, is what your material said.
Yes.
To me, I don't maybe because I've had 33 years as a psychologist and a therapist that I can't think outside of this area. But I don't know how a life coach would stay out of the therapy realm.
Mm-hmm.
Even if you've never been trained in it, it seems impossible to me to coach someone through whatever business difficulties they're having or relationship difficulties or whatever the coaching is about, financial difficulties, and not get into more of what is the realm of someone who's been trained as a therapist.
Yeah. And for me, like, mind you, because I am a clinician also and trained as a therapist also, there's overlap that happens and I can't take the clinician out of me. Like I
Yeah.
will always be like a clinician to my core. However, I do fear that there are a lot of people coming out in society now as life coaches, and it becomes this question of what does that really mean and entail?
Yeah.
Because there are these like fine lines that you walk that go beyond just the um, skill set of that of a life coach. There's a shell and a shallow experience as a life coach. And I don't mean that in a demeaning way to speak about the impact of what life coaches can do and the impact that they can have, but it's shallow. The depth that clinicians go, it's when there are symptoms that are like affecting a person's daily life. And sometimes in life coaching, you open up what some of those symptoms could be.
Yeah.
And
Yeah.
so there's a need to be cautious, like where it does cross over. And I do think that there's more life coaches currently in society than there need to be, because they're entering an area where they can really open the door for a lot of harm.
Mm-hmm.
Which for me is why I kind of look at it like if somebody is doing life coaching, I think it's important for them to align themselves with a clinician so that they are working closely when it
I
does cross
totally
over.
agree with you. Totally
Yeah.
agree. And
Mm-hmm.
I know I live in Arkansas is a fairly rural state. And so, people may be listening, or I mean, other people who live in other states or countries may, well, one, I don't have time to do both. Two, I don't have money to do both. Three, I can't even find both.
Mm-hmm.
So, that may seem sort of like a pie in the sky kind of thing, but I agree with you. The other thing that you talk a lot, or I read some of what you'd written about, is colorizing.
Colorism. Mm-hmm.
Colorism. I can't read my own handwriting.
Mm-hmm.
Colorism, and I have, especially my clients of color, have
Mm-hmm.
told me about their experiences with this,
Mm-hmm.
and so it's. But I really think it exists with many cultures, don't you?
It does. So colorism is within persons of color, now we use the word global majority, though persons of color, where lighter skin tends to be more favored than that of darker skin.
Mm-hmm.
And as a child, I was aware of this. And being somebody of darker skin, I was aware that there'll be people that would say certain things like, you're pretty for a dark skinned girl, or
Right.
you're pretty for a black girl. And then there would be, again, even amongst Black people, a favoritism towards light.
Mm-hmm. Mm-hmm.
And part of that is even within our our greater society, there, you know, once there were Black individuals who appeared very white, and they would do what we would call passing,
Yeah.
because there's favor and there's privilege that comes with lighter skin, fair skin, or being white. And so, as a child, I knew colorism among Black people.
Mm-hmm.
And then as I've grown older and as I've done more research, and as I became a clinician and that of a professor specifically in the area of diversity, I found out among Southeast Asian populations, it's the same thing. Among
Mm-hmm. Mm-hmm.
Asian populations, same thing. Latino populations, there's even like creams for lightening skin. And
Wow.
a large part of it all surrounds this area of it's not so much individuals wanting to be white.
Mm-hmm.
It's
Mm-hmm.
more so people wanting favor, people wanting privilege. And it's embedded within our culture or within our society, this lenience toward, or this leaning towards lighter skin, fair skin gets that of privilege, gets that of beauty standards. It's changing and shifting over time. But it does very much impact our identity development in terms of what it means to be a dark skinned Black woman, and what it means in terms of my attractiveness and self-esteem and self-concept. And that's true, like, again, across several persons and populations of color.
Mm.
So part of it is, you know how Eric Erickson has his different stages of development, and identity development tends to be that happens during adolescence. What research shows is that for persons of color, there's an added um, layer to identity development and becoming secure as who you are and in who you are. And so part of the approach that I take is like helping people see the beauty of all shades, and helping people get to a space of acceptance of who they are, and that society doesn't set the standard for beauty, you set the standard. But allowing space for people to talk about colorism, and acknowledging that it's even there, gives the opportunity to peel back the layers of where does it come from and why has it been there? And it's there because of people fighting for a space of privilege. Privilege is connected to fair skin, like that's in there. But we amongst each other don't have to have this battle of colorism to where we discriminate against each other. There's enough of that happens on a social, societal level as it is, that we don't need to do it within group.
Let me ask you another question. I was talking about, when I was writing that episode about cultural humility and cultural competence, I was talking to a good friend of mine who's half Palestinian, and she's one of my, if not my best friend. And she reminded me something I've experienced it here in Arkansas several times, of misogynistic kind of bias. And in fact, when we sold our house the first time, the people who bought it didn't look at me. They would only converse with my husband. And I finally, I said something, and then later my husband noticed it, and he said, well, I'll just wait and say, Margaret, what do you think? And, but what happens? Because that is a bias. I'm 71 years old. I'm certainly experiencing ageism. But what happens when a person of color hears a white person say, "Oh, I know how you feel"? Because I don't think that's true, and
It's
yet
not.
I also don't want to disparage my. It's just, I don't know what is that like.
The experience of that is one in which, like, many persons of color I've had conversations with many of my friends who are also persons of color, and that experience is one that all of us at some point or another have experienced.
I'm sure you have.
Yeah, and it's one of those things that makes our heads kind of tilt, like, you don't get it.
Yeah.
And it's this piece of where you can't understand something that you just can't understand because you're not experiencing it. And you can have an empathy and an awareness, but not an understanding. And when it's a very dismissive feeling when somebody's like, I get it, I've been discriminated against too.
Yeah.
And it's not to be dismissive of the discrimination that they've experienced. Like, as women, we experience discrimination all the time. We experience the biases that happen in society from misogynistic views, most definitely. But it's almost like, for me, comparing traumas, I'm very cautious to not compare one trauma versus another as well. That trauma's worse than this one.
Right.
They all have their own lane in which they have their own intrinsic, like, details of what the experience is like. And by overlapping them or grouping them together, it's dismissive. And so I think, like, the biggest summary I have is that it becomes dismissive. And there's a difference. You heard me mention earlier allyship, where I think that being an ally is so very, very important. And to me, there's certain aspects of being an ally that's important, meaning learning and knowing when to listen, when to speak, and when to amplify the voice of the unheard. And all three of those are important because there's times where somebody who is a person of color just needs you to listen. Just hear what my experience is. Don't comment. Don't try to over relate in ways that you can't.
Right.
And don't try to speak for me. Just listen.
Mm-hmm.
And then there's times where there is that piece of speaking, of having a conversation that asks questions, that offers a genuine curiosity for learning and growing and growing a genuine understanding. And then there's amplifying, because there's moments where some of my white friends can have conversations with some of their white friends that will be heard in a way that's so different than what would be heard from me.
Mm-hmm.
And so that's when it's knowing when to amplify the voices of the unheard.
Mm-hmm. That's very well put.
I think the biggest piece is just like, as clinicians, we have like a healthy burden of responsibility and accountability to the people that we see. Mm-hmm. And just in general, like once you get that privilege of becoming a clinician, there's responsibility that comes with it that we can't forget. And it's a responsibility, yes, to our clients, but also what we represent in life and in society, and examples that we've got to be aware that we're setting and change the nature of, how we talk about our clinical work and the people that we see, and making and normalizing seeking therapy, and understanding that although there's been progress to reducing the stigma associated with seeing a therapist, there's still work to be done. And that it's still not easy for people to take that first step of calling and saying, I need help. Mm-hmm. And when somebody does, we need to do our due diligence to make sure that we are giving them the services that they deserve and not causing harm. And also accept accountability when we have to do any and everything that we possibly can to repair relationships that have been broken.
So what is in Patricia Dixon's future? Where are you going with all this?
I am excited. I think in the future, I'm actually going to be a part of a upcoming docu-series that's going to be about therapy harm. And so that is unfolding, and I'm looking forward to that. Mm-hmm. And when that comes out, I'm going to be sure to let everybody know.
Of course.
And the beautiful part about that is they're going to be doing a high focus on those who've experienced therapy harm. Mm-hmm. And then also in my future is I've been doing more work with first responders and doing because I think the culture of first responders is changing to where it used to be don't talk about the things that they encounter, but seeing the statistics of first responders being 2 times more likely to die by suicide than by the call, it's a problem. So I think as the departments are becoming aware of that, they're inviting me in to do workshops, and I'm continuing to grow that area. So that's like on the horizon right now for me.
That's wonderful. Good for you. Good for you. And how can people find you?
They can find me at my website, www.manateecounseling.com. Or also I have a second website that's www.patriciasdixon.com.
I've loved having you on. Thank you so much. I got to ask you questions I've been wanting to ask somebody for a long time.
I appreciate the conversation. Like, these are the conversations that are needed. They lead to growth and understanding. So thank you.
You're welcome. Thank you. I think it's so important for every profession to look at the things that aren't getting done correctly by members of that profession. Please, if any of these things have happened to you, know that you can report to the licensing board of the therapist you saw, whether that be social work, psychology, licensed professional counselors, marital and family therapists, whomever it is. So please know you can report that behavior to those licensing boards in every state of the United States. Thanks as always for being here. I know you have a choice. We're coming up on our anniversary of 10 years of SelfWork. And some of you have let me know fairly recently that you've been here a long time, and I appreciate that. But if you're new to SelfWork or you tune in weekly, I appreciate you being here. Please leave a comment, a review, wherever you listen. Go to drmargaretrutherford.com and subscribe there and join the conversation, as I like to say. And you'll get a weekly newsletter with both my weekly podcast as well as if I do an article for that week. So thanks again. Please take care of yourself, your loved ones, and your community. I'm Dr. Margaret, and this has been SelfWork.